Pediatric Lounge, a podcast taking you behind the door of the physician's lounge to get a deeper insight into just what docs are talking about today. From the clinically profound to the wonderfully routine and everything in between. When you start with PCC, you get more than an EHR. As an active participant in the pediatric community, we're proud to offer a lively peer community of PCC EHR users, a free annual users conference, and new resources that empower you to prioritize your patients. Learn more at pcc.com. Again, pcc.com. Good morning, George. It's Tuesday morning, and I will be visiting your home tomorrow.
So today we have another spectacular guest, Dr. Anthony Orsini. And the topic of discussion for today is going to be a physician's journey from general pediatrician to neonatologist and how to deliver bad news. It's all about the delivery.
Dr. Orsini is a pediatrician, neonatologist, author, podcaster, educator, father, and master communicator. I had the privilege of meeting him at Nicholas Children's 59th CME, and by making a joke about my Spanish, he taught me how to communicate news to parents. Not only bad news, but important news, something that I have incorporated into my clinic days every day. As an aside, bought this wonderful book, of which he's the author on Amazon, and I encourage everybody that has to deliver news to parents to read it. If that wasn't enough, I bought it on Amazon, and I was a cheapskate, so I bought it used, and he sent it to me autographed. Welcome, Dr. Orsini. It's a joy to see you.
Thank you for having me. I've been excited to speak to you people today. I've been looking forward to this, so thank you.
Dr. Orsini, we always ask our guests, why did you become a pediatrician?
Yeah, I get that question a lot. I think the simplest answer is that when I was training, I entered medical school thinking I wanted to be an orthopedic surgeon. I was an ex-athlete, and that's what most ex-athletes want to do. But when I did my rotations, the pediatricians were just the nicest people. They were always the nicest doctors. They always seemed to be the happiest. I loved kids, and I really cherished and looked up to them and said, these guys go to work every day happy and enjoy their life. And I think it was really the people that I ran into as I was training.
Wow. Now, you had a wonderful TED Talk, and I encourage the whole audience to go listen to it. And the TED Talk was the reason that you are passionate and motivated to create a whole new way of communicating with our patient. Would you mind sharing that story with our audience today?
Yeah, so I was a senior physician, so a senior fellow. So I was almost done with my training, and I received a typical call, always happens at 3 a.m., to pick up a baby in the middle of the night who had severe pulmonary hypertension and from Cunningham aspiration. We went to go get the baby, and in transport, we got there, the baby was barely clinging on to life. He was 100% oxygen, he was on the ventilator, he had severe pulmonary hypertension, and his sats were in the 60s. We got the baby back into the ambulance, and all through the time that we were traveling back to Philadelphia from New Jersey, he was not doing well. Fluid boluses, epinephrine drips, etc. I'm calling my senior physician, trying to get advice from him. He just says, just get the baby here. The baby needs ECMO. I got the baby there, but by the time we were getting to the NICU, I had already started CPR. My senior that day, I called Dr. Cunningham in the book. That's not his real name. My senior that day was one of my mentors, one of the physicians at Thomas Jefferson University where I trained that I looked up to. He really was the nicest, most compassionate man and brilliant, just super brilliant, the kind of doctor I really wanted to be like. And he and I coded this baby for almost 45 minutes, and despite everything that we did, the baby died. I didn't know it at the time, but the nurse told me right afterwards that the father had followed the ambulance. He was waiting for us in the waiting room. Totally didn't know that his baby had died, had no idea. Now, a lot of people assume that I teach communications and specifically bad news because I've had some horrors in my life, and I've heard when I was younger, I had some experiences, and to a certain extent that's true. But the reality is that as I was finishing my training, I felt so confident in my clinical skills. I really was trained at a wonderful place. I was ready to go out, become an attending. But the thought of telling someone that their baby died or that their baby was going to have severe brain injury just frankly scared me to death. When the nurse told me the father was there and I saw that Dr. Cunningham was my senior, what better opportunity for me to learn how to communicate bad news than to watch Dr. Cunningham? He was, again, the nicest person I'd ever met. I asked Dr. Cunningham, I said, do you mind if I come with you to speak to the father? Together, we walked down the hallway, knocked on the door. He opened the door, and even 25, 30 years later, I still can't believe what happened. But this kind, compassionate doctor just blurted out, my name's Dr. Cunningham, your baby's dead. The father, I remember it just like it was yesterday. He literally punched a hole in the wall. He knocked the lamp down. He was totally blindsided, let out a scream that I had never heard before. And Dr. Cunningham put the back of his hand on my chest and he just said, let him be. And so the father calmed down after a few minutes. He sat down and then Dr. Cunningham sat with him. And really at that point, you really saw who the real Dr. Cunningham was. He was compassionate. He said all the nice, best things. Of course, the damage had been done, but we spoke to the father for a few minutes and then escorted him to go see his dead son. I said to the father, I'll give you some time alone. And when I walked out into the hallway, Dr. Cunningham was waiting for me. And he grabbed me by my scrub and he pulled me in within a few inches to my face. And I could see actually was crying. And he pulled me in really close and he said very loudly, do you see what I just did? And I shook my head, yes. And he goes, don't ever do that. And then he turned around and walked to the end of the hallway, went on the fire escape and cried for the next minute. And that was really a profound change in my life. At that point, my thoughts were, if this kind, compassionate, accomplished physician couldn't give bad news and actually made things worse in the worst of time, really, what chance do I have? I'm just a kid from North New Jersey. And so it was really at that point that I decided that I was going to answer two questions. One, is there a right way and a wrong way to break bad news? And two, if there is, can it be taught? And so when I graduated, my first job was at NYU. I started to research that there's no literature involved in that. This is 1997. And so what I decided to do is, well, let's find out from people. And so I sat down with nearly 100 couples, parents, widows, widowers, people who've been diagnosed with cancer. And we had very nice open-ended conversations about, tell me the time that you found out your husband died. Tell me about the time that you found out you had a stillborn child. Tell me about, and then I asked them, what was it that the doctor did? It's amazing how much they remember the detail. It was really shocking how they would remember the color of the doctor's pants, what their perfume was, etc. But it was a clear pattern about what things that the doctor did or said that seemed to help and what things the doctor said or did that seemed to make things worse. And so after 10 years of doing that, I came up with my first communication program, which is called Breaking Bad News, and the rest is history.
So I'm going to just interject for a second, because when, as general pediatricians, we hear an neonatologist breaking bad news, the first thing that comes into my brain is the child is dead. That's really bad news.
Yeah.
But every day, and more so now that I'd say a quarter of pediatrics is psychiatry and a quarter of pediatrics is pediatric endocrinology, we have to give what to the parents are really bad news. Your child's autistic. Your child is diabetic. Your child's hypertensive. Your child is depressed with suicidal ideation. Yes, it's not your child is dead, but I can only imagine sitting on the other chair in that exam room, how hard those news are to receive as a parent. So I think your program has an impact beyond your child is dead, your child is going to die, your child has cancer. It's a method that can be used effectively every day in clinic. And it's in some ways, wonderfully simple that I think can do a lot of good. What is the Orsini Way? You have a couple of steps that you call program.
But yeah, so after I came up with this program, I came up with this acronym, and I'll go over that with you. I had answered my first question, and that was, is there a right way and a wrong way of giving bad news? And you're exactly right, Herb. Bad news could be, I'm sorry, but you sprained your knee and you can't play in the state championship football game, right? That's devastating news to a high school 17-year-old quarterback. So there's a lot of different bad news. And when I developed the acronym program, I wanted that acronym to work for any kind of bad news, whether it's you can't play in the football game or your son just died. But also the acronym works now that we teach patient experience and other things. That's where the Orsini way of communicating came into. And the way we use that acronym in most cases is through the Breaking Bad News program and the Orsini way. We use professional improvisational role actors. I came up with program. I tried to say, okay, how could I teach this? I started using volunteers. We started with residents. You play the doctor kind of thing, and you play the patient. That was a total disaster. Nobody could act. Medical students could act. There was giggling going on. There were peers. So we scrapped that. Then I went to simulated patients. We were coming out just then. A little bit better. We still don't use simulated patients in most places. Simulated patients are excellent. They do a wonderful job, and I love them. But most of the simulated patients aren't trained in improv. They're very scripted. And it's, as you can imagine, giving bad news in that kind of improvisational role playing, that the actor really has to be able to have some depth of acting. Because the thing that I'm teaching the doctors when we do a program in Breaking Bad News or Difficult Conversations or whatever program we're doing is that the response that you get from the person on the other side is largely due to how you made them feel. And that's why it's so important that we use improvisational role playing, because Herb, if you were doing this with me and you were doing a difficult conversation, it could be conflict resolution, it could be bad news, and you said something to make the actor feel that she needed to be defensive, she'd become defensive. If you said something that made her mad, she would get mad. If she wanted to hug you, she would hug you. So that's why it's really important. So we use the program, and it's called an acronym, but it's really not. I like to call it a roadmap, because I don't want people to get start to say, okay, I'm giving bad news, and then roll their eyeballs up into their head and say, remember, okay, what was the P? I want this just to be a roadmap for teaching, but it needs to just the general
to prevent medical malpractice cases, because most of the cases that happen back in the day, pediatricians would ask people to get sued, never got sued. Fast forward 25 years, 30 years. Oh, geez. They'll sue anybody just because maybe it's the lottery. And usually I've reviewed a lot of cases, and usually somewhere along the chain of events, somebody said something. And it's that sentence that somebody said that triggers, maybe I should sue this doctor. And then everything starts. If people just are careful in the words that they use, they could prevent a lawsuit, even if there is something bad and devastating.
But it's only that you use. It's your body language, which we are not trained and we are not aware because it happens so fast. The amygdala and your body language works on nanoseconds.
Yeah.
And our brain, our frontal lobe, our thinking ability works in minutes.
Yeah, like George is exactly right. I do a significant amount of work for malpractice companies, doing some training of their physicians, but also teaching them in keynote lectures, etc. How do you communicate to build trusting relationships? The American Bar Association said many years ago in one of their conferences that patients are reluctant to sue for physicians they have a relationship with them. And the title of the little paper was "Stop Wasting Your Time." In other words, don't call up that patient and say you had a bad outcome. And there's a study at the University of Florida, Gainesville, that showed that you can build a relationship with a patient in 56 seconds. So we're not talking about long-term relationships here. We're talking about how you smile. Our brains are assessing someone's body language 3 million times a second. That's crazy. And so by what we teach physicians how to do is build that relationship, especially emergency room doctors. How you smile, how you sit down, your tone, your inflection, your cadence, et cetera, all make a huge difference. 81% of malpractice lawsuits name communication as one of their top three reasons for suing. And 90% of lawsuits are won by the physicians. If we can somehow get patients to not sue just because they're mad or because they feel that their questions weren't answered, just think about the financial ramifications that would have on healthcare and saving in malpractice, frivolous malpractice lawsuit.
So I know you don't like the role playing, but we don't have the time or the money to actually have actors today. I was going to go through the steps as you have taught me and use George as the dad of the patient.
Okay.
And it's not perfect, but it's better than nothing. I'm going to tell George, as a parent of a 2-year-old, that his child has been diagnosed with diabetes. And so I'm going to come into the room as you taught me. I am going to adjust my chair to be closer to George. And I'm going to sit down. And I'm going to put my hands like this because this means I care, and I'm in a tripod position. And this is how I'm preparing to deliver this news to George. And so, George, thank you for coming in today. George, as in our practice, we screen every 2-year-old for anemia, lead levels, and autoantibodies for diabetes. Your daughter's blood level is normal. She does not have anemia. But unfortunately, she did screen in for diabetes.
Wow. What does that mean, Doc? I don't understand.
We know now that diabetes can be diagnosed early before you need insulin. And so we like to know that. So right now, it doesn't mean very much. And what I mean by that, George, is that I would like for you to allow me to make sure I have the diagnosis right, repeat the test, and I'm sure that you have had a A1C level measured at your internist at one time or another.
Yes.
So I'd like to get those 3 tests done today to make sure that your daughter is not in need of insulin and that she actually does have diabetes. Is that something we could do?
I guess we can do that. We'll have to call my wife because I want her to be on this conversation also. Maybe we could do it next week.
I would really like to get that A1C done today to be safe.
Okay.
Then when the A1C will come back within a day or two, bodies take 7 to 14 days to come back. And then I wonder if we could have Delia and you come back in if they're positive, and we can talk about what we need to do together.
If the child has diabetes,
Really,
he's going to be on medicine for the rest of his life.
not initially,
Is the
George.
kid really sick? Is he going to be hospitalized? Oh my God.
We're going to try to prevent your daughter from having to be at the hospital at any time. And we're going to count on some wonderful pediatricians that I am friends with, both at Nicholas Children's, like Dr. Bustamantes, or in Denver, where they're the national experts on diabetes for children. The first step is to make sure we have the diagnosis right, which we always do. If she had been tested and she was anemic, I would like to repeat it to make sure that I do have the right diagnosis. The second step is going to be to monitor her glucose to see if she needs insulin. And so I don't want us to get ahead of ourselves. I want to make sure that we have the diagnosis right. And then we come back and sit down, and I will guide you through this process, and I will be there for you and Dahlia and your daughter all along. And I will make the phone calls necessary to make sure that if we need to go see a national expert.
But I don't understand, Doc. You just told me you did a screening test in the office and it was positive. Does she or does she not have diabetes?
It is positive, George.
So that means the child has diabetes?
It does appear like your daughter has diabetes.
Okay.
I would like to confirm the diagnosis and make sure that her glucose or her sugar is normal.
Well, if the child has diabetes, how can the blood sugar be normal?
In the early stages of diabetes, you do not have elevated glucose, just like some people are pre-diabetics and they still don't need therapy.
But can we just, instead of insulin, just put her on a diet and everybody has diabetes? Maybe if we just put her on a diet, then we don't need to do anything.
Absolutely, George. her glucose is normal, making sure her vitamin D levels, her diet, and her exercise and her BMI are normal can help us delay the onset of the use of,
My child is 2 years old. She's not overweight.
like you said, diet, good healthy lifestyles, and normal vitamin D levels do have a protective effect.
Oh boy. So the child's going to be on medicine for the rest of its life. That's
The information that we have is that if you test for these two antibodies positive, there is 100% chance that you will need insulin throughout at some point in your lifetime. We don't know if tomorrow, 4 years from today, 20 years from today.
You have the best specialists in the country.
Yes, we can. If you want to go to the best, we can send you to Dr. Simmons in Denver. They do most of the research in type 1 diabetes. Locally at Good Sam's, we have 3 great pediatricians that specialize in this problem. We can send you to Nicholas Children's in Miami, and I can make the call to one of their pediatric endos there that do nothing but this all day. If that would make you feel better.
Yeah. We live in New York.
We could certainly set up a consult with the peds endo at Good Sam.
Okay, that might be better.
So can we redo the blood work and then have you and Delia come back so we can talk one more time?
Okay, we can do that.
Great. Thank you, George. Dr. Orsini, where did I go?
Very good. Very good acting, George. I think that
These are all things you had experience with patients. I didn't give you the aggressive one. I should have.
Yeah. Well,
It's your fault. Why didn't you check earlier, Doc? Before he was.
Yeah. So, I think you didn't get aggressive, and nor would my actors get aggressive, because George did a lot of things right. Herb did a lot of things right. He didn't trigger you by having certain tones and did certain things wrong. I took some notes, and overall, really great job. A couple of little suggestions, and this is probably a good time to go over the program acronym for those people. But the P is for plan and position, and Herb, you were exactly right. Where you sit is a big deal. When you're giving bad news, it is not an option to do it standing up. Okay. It's bad on so many different levels. Someone can pass out. It sends the wrong message. It tells the patient that you really don't want to be there, that you're looking for the door. And then I always joke that the Orsini law is never ask a question unless both answers are acceptable. I tell all my residents and doctors that, which means don't ask somebody if they'd like to sit down, because the answer could be no. We know that's not in their best interest. So what I always say is, I'd be much more comfortable if you would sit down and just hold your hand out by the chair and wait for them to say, which sends a silent message that you're not going to start until they. So Herb did exactly that. He sat down, he used correct body language. If you're giving, part of the plan is, how bad a news is this? Is this a death sentence, or is this a diabetes, which is certainly really bad news, but is treatable? And so we have to use the proper body language. If you're giving bad news and you say all the right things and you're not using the proper body language, is going to create things. So the P is for plan and position. And so part of that plan is to say how bad a news this is, and how do I want to approach this? I call this the Clint Eastwood thing. Clint Eastwood is the director, right? So you're the director of this scene that you're about to have when you're giving bad news. So this stuff works for conflict resolution when you have an angry patient, which we deal with all the time. It's the same concept. So George, Herb did that very well. He did what people didn't notice was the first R is called review. The number one rule of breaking bad news is never, ever break news suddenly. You'll always break bad news gradually. That doesn't mean you're going to prolong it out for the next 10 or 20 minutes and then say, oh yeah, your wife died. In most medical schools today and residency programs, they're teaching an acronym called SPIKE. And I won't go over what SPIKE stands for, but it was created in 1999 by some really great oncologists. One of the things that SPIKES tells you to do is, SPIKES also recognizes that you never want to blind somebody with bad news, but it teaches that you should break bad news, prepare people for bad news by saying, I have bad news. So if you're walking into a doctor's office and you're waiting for your pathology report or your blood work, and the doctor says, I have bad news, that's not preparing them for the bad news. That is literally the bad news. So what happens to your fight or flight when a doctor says, I have bad news, you stop hearing, right? You get this big adrenaline flush. So what we want to do is show that you have bad news and not tell. And what do I mean by that? By doing the proper review, like Herb did. Start from the beginning, even though the person may know why you drew all the blood. In this case, it was just a routine blood work. But perhaps someone's coming in for their lung biopsy results and or they had a bone marrow. You can start from the beginning again. What I really liked what Herb did is he said, I wish your wife were here. Okay. And what you just did, Herb, there was you foreshadowed that this was going to be a serious conversation. So, because subconsciously the patient was saying, this must be a serious conversation. Why was he wishing my wife were here also? So that was really excellent that you did that. And just go over a little bit from the beginning of what you did. You did that very well, Herb. This is why we do it. This is what we found. One of the words that I would say that we can use more in general is two words that are really great is concerned and worried. Okay, so I always say doctors should never use the word think. Think means you don't know. And you didn't use that word, Herb, but I'm just, as a little extra tip, is I looked at the preliminary results. And after looking at those results, I'm very concerned that your son, is likely to have diabetes. And I don't want a doctor who thinks because he doesn't know. Like, who doesn't want a doctor who's concerned or worried? That's the kind of doctor that I want. I'm concerned that you have diabetes. I don't know for sure, which is exactly what you were trying to say in that improv. And further studies are going to need to be done, but I'm concerned enough that we need to deal with this right now. So that's just one of the notes that I put there. So that's the first. You use that review, and then you use the proper body language, which Herb talked about, leaning forward, making eye contact. And then that's the O is observe. Physicians were trained from day one on how to observe patients, how to see their gait, how they speak, what can I pick up, shaking their hand, see if it's a weak handshake. But we really don't realize that they're making 3 million assessments per second on our body language. And one of the things that is really interesting because it's fascinating about medicine, about verbal and nonverbal language, is that if your verbal language and your nonverbal language are in sync, the physician can say everything correctly, say all the right words, concern, do the review, say they're sorry, all that, but has a casual body language. The human brain is going to have two conflicting messages. He's saying the right things, but he's leaning back casually like he's talking about the Miami Dolphin game. And almost always that will create anger and distrust. And really, that's what this is all about. Medicine, whether you're giving bad news or you're having a routine patient experience with routine office visit, it's all about building that trust right now. So it's really important to do all that. And then that's where that second R comes into. So the G is gradual. We talked about that. If it's not bad news, the G stands for genuine. There's a routine office visit, being yourself. I talk about it in my TED Talk. You really can build trust when you're not all business. Talk about something first before you get into why are you here today will really settle everybody down. So the G is either gradual or genuine. And then the second R is that relationship. We could solidify that relationship, saying things like, I think when George was saying how nervous he was about the diabetes, et cetera, having that, solidifying that relationship at that point by saying this is something serious and could be, if true, a lifelong problem that we're going to have to deal with. But I'm going to get you through this. We're going to get through this together. I have great people that I'm going to send you to. I'm still your doctor. That's the accountability, because so many people think once you send them to the diabetic doctor, that the primary doctor's not involved. I'm still going to be here. I'm going to be making sure that everyone sees you in a timely manner. Herb, you did a really great thing and said, I'll be happy to give him a call. That's a wonderful thing. You went that extra mile and then set the tone for the next meeting on what's going to happen next. And overall, that's exactly a wonderful way of doing it. I would just say a little bit more of a review, use the word concerns, and then solidify that relationship a little bit more by saying, we're in this together. Never say I understand, right? That's the worst thing you can ever say when you give a bad diagnosis. but you can say, I can't imagine how difficult this must be. Or I can only imagine how difficult it must be having a 2-year-old, thinking about them having diabetes for the rest of their lives. All I can tell you is I'm going to be here and we're going to get through this together.
Wonderful. You don't know how much I thank you for this. This is a tremendous gift. Because as a pediatrician, the worst thing is tell someone bad news on a disease that you won't be managing. It doesn't matter what it is. The count's 40,000 in a 2-year-old with a hemoglobin of 6. That's leukemia. But I don't do the chemotherapy. And the anxiety that provokes to go in there and have a conversation with no toolkit. And this is a toolkit where I can diminish my anxiety and still do good for this patient with a horrible diagnosis. I'm going to touch a little bit about what you call the 5 principles of communication. You've already pointed out, but particularly principle number 5, it's all about the relationships, because that's an underlying theme of your book over and over again. How important are relationships to the work that we do as pediatricians?
In a world where I think, whether it's due to COVID or not, I saw a recent study that said 43% of people between the ages of 18 and 36 stated that they felt that they can get a diagnosis using Chat GPT and Google just as accurately as going to their physician. Okay, so that says a lot. Now, whether that's COVID or not, I don't know. But I see it in my practice, and I'm sure you see it in your practice. There is a distrust out there of the physicians, right or wrong, there. And medicine to me is about the human connection or the relationship between you and your patient. I do a lot of work on physician burnout as the wellness director of the NCPS. And if you really look down on why we became doctors, the easy answer is to help people, right? But that's not why we're doctors. That's what we do. Because you could have helped people by being a fireman. You could help people by being a police officer. You could help people by being a multimillionaire and donating money to Nicholas Children's. There's a lot of ways of doing that. So why did we do it? We did it because deep down inside, if you really look at it, our why, as Simon Sinek would say, is cherish those relationships. So when you have a bunch of charts that need to be dictated, you have all this extra stuff that's weighing on you. But when you close the door to the exam room, that is your time to enjoy with that patient. And so we are able to form a relationship with a patient by being a genuine person, by how you smile, different ways of smiling. And one of the things that I'm fighting is that I get a lot of people to say, it's hard for an ED doctor to form a relationship, it's hard for a neonatologist or a newborn. You can build trust by coming in, forming that relationship with the patient by the way you sit down, by the way you smile, by the way you're not feeling rushed, making them feel rushed, talking about something personal, sharing something. If the person's wearing a Yankees hat, talk about the Yankees for 2 minutes before you get into it. Think about this. If you were in France, country, and you were in the hospital and no one spoke English, you'd be really scared until somebody came in and said, hey, how are you? Where from the United States are you? I'm from Florida. And so that's the relationship that we can. And I've proven it over and over again. You can form a relationship and find commonality is the word that you're looking for with anybody. It doesn't matter what race they are, ethnicity, where their socioeconomic background is. And we do these little exercises where I'll flash a room, a hospital room or a treatment room or a family up on a screen for 3 seconds, shut it off, and then say, okay, George, tell me one thing about that room that you can relate to. And it may be donuts in the corner of the room, or it may be bright, shiny sneakers or running shoes. Whatever it is, you can do it. If you form that relationship, not only will it help you with your patient experience scores, which we have shown by improving 60%, it'll help you build your practice. It'll stop you, as George said, from getting sued in many cases. And so it's really about forming that relationship. And that doesn't only help the patients, it'll help your own well-being. It will decrease physician burnout.
I think this relationship thing is something that's entertained by people like you guys, us older generation doctors. The younger kids, I don't know, they seem to have this, they're a patient. I have a job. This is a medical record. Is that something that's taught or they grew up with, or I don't know where it is, but I'm seeing the relationship going away.
That you see it today, people go out to dinner and everybody's got their nose buried on the cell phone. They're not building relationships with each other. That's why we have such problems.
But for instance, as soon as I get off this podcast, I'm giving a lecture to the incoming first year medical students for Quinnipiac Medical School. I do it every year for them. And we actually show my TED Talk. They show my TED Talk. And then we talk about that human connection and how important that relationship is. I think we need to get to them that early. What medicine has totally confused people is that they have confused the word information and the word communication. And we have a group of people coming up who think that communicating is providing accurate information. And I will say to them, then I would say, for instance, Herb, what was your main goal for that diabetic talk? And you would say, I wanted to give them all the information. And I would sarcastically just say, why don't you just hand them a Google Doc and walk out of the room? Nothing's more information to Google. And then you'd say, that's absurd. And you exactly, not about information. It's about the relationship with communication.
Yeah, absolutely. Relationships are extremely important. Not every time you go out on a date does it become a marriage, but it can still be a relationship. And so when I was in the ER, what you said rings totally true. I had to very quickly build a relationship, and it was very intentional. I wore street clothes because I wanted to be seen as the expert, the physician. The lawyer never comes into a courtroom to do his summation in scrubs, pajamas. They come in a suit. So I come in on with a lab coat, a button-down shirt, and slacks. I used to have dress shoes, but now I'm getting older, so I have to wear tennis shoes so I can get through an 8-hour day standing. So I made some compromises. And I always sit down to the point of being rude. It doesn't matter what the conversation is. If the patient is in my stool, I will, which is the parent, I will say, would you please sit in these chairs and sit Johnny on the stretcher? That's my chair. I'm going to sit down. And then I sit down. It could be a well-child exam. Everything is normal. I always sit down. And then, as you said, I always find something, whatever it is. It's hot as all get out in DC today. Miserable. Oh, yeah, they say. And then I say, what can I help you with? Until they've told me what they want, I don't go over growth curves. I don't go over labs. I don't go over consultant reports, nothing. And it's amazing how even in the emergency room or the urgent care, people come, not everybody can like me, come to trust you, but it's all intentional. It's all
100%.
intentional. It's all a game. But if you want to do good, you got to play the game because the brains come as they come. I cannot switch the amygdala on people to be reasonable, rational every single time. I just have to switch that amygdala in a way that it will allow me to carry the message that I want to carry and do good. You've touched a little bit, but I think, and I learned this from Roy Cioletti, who passed away 20 years ago. He was from New Jersey. Camden, I think, is a bad town in New Jersey. That's where he went to medical school because he used to say, nothing is as bad as Camden. If you can survive Camden, you can do anything, Herb. And he used to say, he was 20 years older than me, so he would have been 80 this year. And he used to say, at some point you will master ear infections, strep. And the joy of being in the office will be the relationships that you have with these kids and their parents. And that's what keeps you going. So other than those words from Roy, how else does great communication prevent, immunize against burnout when we're all burning out and leaving the profession early?
It's a great question. And right now, wellness programs, et cetera, which you have some wonderful ones at Nicholas and other places. But what I tell people is that every day, I can guarantee there'll be one point in the day where either me, you, and George will become task-oriented. It happens. Don't fight it. It's going to happen. You're going to get into a groove. You're going to start seeing patients. It's okay if that happens. But what I want you to do is once you're aware of it, you need to pick it up as fast as possible. The human connection is not only what the patient needs, that human connection is also what you need to go home feeling fulfilled and waking up inspired every single day. Wendy Dean talks about moral injury, and moral injury occurs when you act contrary to your core beliefs and values. And so when you and I become task oriented and we don't sit down because we're in a hurry or we don't enjoy that relationship, that causes little bits of moral injury over time. And mine was of one major moral injury, but every day there's these little moral injuries. Then you go home feeling depressed, and then the next day you go home feeling more depressed. And it's because you've forgotten your why. Your why is that you enjoy that relationship. And so that relationship is going to help you with your own well-being. And you have to think about, there's doctors who've been practicing 40 years, and they're totally immune to physician burnout. They're happy every single day. They're enjoying the people that they meet every day. They're enjoying their team members. They walk in with a smile. They're happy to be there. When we do a patient experience program for, say, a large unit, we tell part of what all the people in the unit sign up for when they do our program is they promise each other that they're going to help each other not become task-oriented. Let's recognize that I recognize that it's bad for me and it's bad for the patient. So I would say to everybody from the housekeeper all the way up to the chairman, that if you see me at any point looking task-oriented, talking to a patient with one foot outside the door, rushing, not enjoying what I'm doing, please remind me that I'm becoming task-oriented. We have a code phrase. We say, hey, Dr. Orsini, it's all in the delivery. And my response would be, thank you, George. You really helped me with that. I didn't realize it. And we would do that for each other. You don't want to realize that the second half of your day was becoming task-oriented while you're driving home feeling depressed. You want to pick it up soon. So it really does help your well-being. Simon Sinek will tell you that's called remembering your why. And our why is about that human connection and enjoy it. Sitting down, as you said, is 90% of it. Patient will feel that you're in the room longer. You'll save time. Doctors say, but there's no chair in the room. There's always a chair within 10 yards. And boy, if there's no chair in the room, that's actually positive because the patient goes, wow, Dr. Orsini actually went 10 yards out of his way to grab a chair. He must really want to be here. Boy, there's our relationship builder. So it's these relationships and this human connection is going to help us immensely from getting burned out or moral injury, but it's also going to help patient experience. It's like a one-stop solution, if you ask me, for all that's wrong with healthcare right now.
Yeah, I think with healthcare, I'll give you an example of what happened in our office yesterday. This task-oriented process that's happening. Go in, open the computer, see the patient, do your thing, get out. I watched for the first time in a very long time where technology can cripple an office. We had a problem that was a nationwide problem with our EHR yesterday. It was basically click a button, go get a cup of coffee, come back. So physicians have trouble pivoting and adjusting and adapting. So I came to work late at 12 o'clock until 8 o'clock. I came in, I just saw it all in the faces of all doctors. They're all upset because they're clicking and they can't get through their process and they're getting delayed and they're getting upset and more upset. And I came in and I saw the problem, called support, found out that this is a problem. They know on it, top priority, they're fixing it. It's going to take a number of hours. So what do? You got to do something. You can keep clicking and keep doing and keep getting frustrated. So what I did is I realized it's not going to get better. I'm going to be later by myself. So I had my medical scribe AI. I just made sure that there was a lot of details in there. And I labeled each case with the child's first name and last name so I don't mix them up. And I gave them diagnoses. And you know what I did? I spoke to people. I left the phone. I spoke to people. I forgot about the progress notes. I used the EHR just to prescribe a medication and order a vaccine. So 1 or 2 clicks, it was okay. It was when you're doing a multiple of clicks. And you know what? I didn't need the record. Do you have allergies to medicine? Do you have any past medical history? Do you have any things we need to know about? Do you have asthma? And all that stuff got transcribed. I copy pasted all my notes and I left at 8 o'clock on time. And I put this out early to all the doctors. This is what I think we should do for the rest of the day. Not a one followed. They all continued with their clicking and getting upset. And I went home on time and I'm fine.
This makes for 3 other podcasts. But the reason that your team didn't follow is because you told them what to do.
No, I suggested what.
And when you tell people what they do, they will not do it. So
I told them, I think this is what we should do. I already
you told them what to do.
it, and it worked for me.
So I want to touch on something else in the book because it's phenomenally important because this happens all the time. It happens in your personal life, happens with your employees, it happens with your coworkers, and it happens with your patients. And it's conflict resolution. And in the book, you talk about how to systematically approach conflict resolution. And step 1 is what I call tell me more. Walk in, sit down, and say, what's on your mind? And then once they're tired of telling you, I think they've done studies. People will talk for about 90 seconds and they run out of air and then they stop. And then you say, tell me more. And it's another 30 seconds. It'll take you 2 minutes. Then you follow it by some very key words and say, this is unusual. Even if it happens every day, that luggage gets lost at Southwest Airlines. Don't say, oh, this happens every day. We know how to handle this. People are like, I don't care. It happens every day. It's my luggage. Take responsibility. I will take care of this for you.
Yeah.
And hung up. I'm going to ask you, here's that question. I got hung up on this is your idea, not mine, because we're problem solvers. We tell people what to do all the time. I don't tell the parent, your kid needs surfactant. Is it a good idea for me to give surfactant? And no, I go, your kid needs surfactant. I'm going to give it. I'll come back and tell you how it went. And so that's your goal. So what are your thoughts on all those 4? Because it's fascinating how you put it out there.
I love conflict resolution. Again, especially in my old hospital, not too much in where I am now, but I would walk into this very large intensive care nursery, and the first thing the nurse would say, so I'm so glad you're here. This mother's really mad. I like it. It's a challenge. But this is unusual, or you called tell me more. The first topic is tell me more, or I have no preconceived notion. So I think that's really important. Usually if you're asked to go into where there's a conflict, there's already been a conflict, and now you're the manager or someone else is going in, find out what's going on. They expect that you had already done your homework and that you know what's going on. And so what you want to do is disarm them, right? You want to disarm them by walking friendly, by sitting down, crossing your legs. Maybe you got lucky and you found flowers and you happen to know what kind of flowers they are, to talk about something else. Because the person is there ready for a fight, right? They're all ready for you. And now you come with a big smile on and comment about the donut, or complain that your daughter wouldn't get dressed for school today and it's been a really hard day at work, etc. So you disarm them. But always sit there and just say, Annie told me that you were upset about something and wanted to talk to me. And the reason why you do that is if you say, Anne told me that you were upset because somebody didn't change the diaper, or the medication was giving, or the formula was 15 minutes late, the message that you're sending to the person is that you've already investigated this. You've already know the fact. You probably already decided that I'm wrong. And therefore, what's the purpose of me even telling you, right? So by saying I have no preconceived notions and I don't really know what this is about, they're going to be a little disarmed, and then they're more likely going to tell you they're part of the story. So I think it makes it we're on the same level, as opposed to I've already decided. You're right. This is unusual. And I tell the story in the book about my mother-in-law who got an echocardiogram, and 3 days later she's in the hospital. The echocardiogram's not really back. The cardiologist hasn't gotten to see her yet. So you're not helping anybody by saying that. So that's quite interesting. We'll look into it. And then the third one, my favorite word is personally, right? We don't want to talk in scripts. I'll look into it. I'll talk with Susie about getting the medications on time, or I'll see if I can get in touch with the cardiologist for the echo report. If you add the word personally, it just changes it into not a script. Like, one is just word language. Yeah, he said he's going to take care of it. But when you use your body language, touch your heart, I'll personally give them a call. And if they don't answer, I'll keep calling them. And so that puts a face to the task, just to say, okay, I'll talk to Susie, but then you add that word personally, it just becomes much more profound. And it's a really good It's a good technique to use. And then lead the horse to water, or let them think it's their idea. I joke, it's what my wife does, right? So she says, she asks me a question, what I want to do, and she makes it look like it's my idea when she's probably led me down to that restaurant to begin with. That's on the rise right now. Rather than say you're putting your baby at risk for bleeding, and vitamin K decreases the incidence of bleeding by 800%, and vitamin K decreases, et cetera, I really recommend that you give the vitamin K. There's going to be pushback on that, especially if you don't have a trust. But you can rephrase that by just saying, it's perfectly your right as a parent not to give the vitamin K. What I'm really concerned about is that I've seen babies in the middle of the night, even up to a couple months of age, have major intracranial bleeds and really devastated for the rest of their lives. And I just don't want you to have that guilt if that should happen, that you didn't give the vitamin K. And then their response is, well, maybe we should give it. So you're leading them down, like, here's my issue. And then they'll say, why don't we do this? And if you want lessons on this, you call my wife. She'll give you $20 an hour lessons on how to do that. But if it's great.
No more wives, please. Already my life is ruled by Dr. Delia Rogel, who is the scheduler for their practice in my life. No more wives, please.
How would you respond to a patient that says, I don't want to give vaccinations to my child? Nobody gets sick with polio or hepatitis, is sexually transmitted disease. Why are my babies getting it? Or measles or varicella? And they're all childhood illnesses. They don't get sick. So why should I take it? I don't want it.
And that's a big trend right now. And a lot of times you're not going to convince them. Like most of the time you will. But I could tell you that by giving them straight statistics and say, I strongly recommend that you do it, you're not going to be successful. But by painting them that picture of, this is what I'm concerned about, this is what it might look like, then what you're looking for them to say, here's an idea, how about we give this vaccination? Or how about we do this? In the end, you want to phrase things so that you lead them to the water and then they drink, as opposed to just giving them your recommendations, because you'll always have much more success by letting them come up with the answer, letting you think it's their idea.
Yeah, I usually get away with the MMR is usually not a problem for me, because when they're apprehensive about it, I just pull out my story of getting measles as an intern.
I take it if somebody doesn't want any vaccinations, I will say the meningitis and pneumonia vaccines have changed the way I practice medicine. I am no longer doing 2 blood cultures, a bladder tap and a spinal tap on every 9-month-old with a fever. And I don't want to go back to practicing that way. And so if you choose not to give the meningitis and the pneumonia vaccine, I may miss something someday because I'm no longer thinking about it. And I'm not okay with that. So you need to find someone else that is still practicing medicine, like when I started in the late 80s and early 90s, and I couldn't prevent the disease. And I leave it at that.
Another good example is the vitamin K that we use doesn't have preservatives in it. Okay, we haven't used vitamin K or preservatives. A lot of times I'll ask them, tell me what's your objection to the vitamin K? And they'll say, I don't want to give my kid any preservatives. I could just say mine doesn't have preservatives, right? That would be the end of it, but that becomes a little bit argumentative. Or I could say, what if I can get your baby one without preservative? There's a big difference. One is argumentative and the other one is, so with preservatives, if I can get you one without preservatives, would you be okay with that? Like, yeah, none of them have preservatives, but it's just a different angle of it.
Yeah.
All of a sudden now, Dr. Orsini did something really special. He got me one without preservatives, and now I'm okay with that. So that's almost like a win for them, as opposed to just saying, well, we don't use preservatives.
Yeah, I think with the vaccines, people don't even know why they don't want the vaccine. Somebody told them, they heard a friend, a post, some social media thing. They have no idea usually why they don't even want a vaccine.
So I'm going to close with level setting. In management, there are 2 words that start with E: efficiency and effectiveness. Southwest is very efficient. You can make your travel reservations online. You don't have to speak to a human. You can show up. They even let you tell them that you're going to put your luggage, and they print you the little slip. You put it on. They check your ID, and you go through TSA, and you're on the plane. They don't need a lot of people. They use a lot of computers and machines. Effective is a different thing. And I want to read a quote from your book because it really struck a chord in my heart. Throughout this book, we have discussed the deficiencies in healthcare, which have resulted largely from poor communication. Medicine had lost its way. Advances in technology, pressures to be more efficient, not effective, and attempts to improve the patient experience by erecting bright, shiny new buildings have misled us into forgetting what medicine's truly about. One human being comforting another. It's a relationship. Those are very beautiful words and another great gift that you have given our community. Thank you. How can people reach you if they want to be part of your program, whether it's pediatrician, large pediatric groups, hospitals?
Our website is theOrsiniWay.com, or you can reach me at Dr. Dr. Orsini, and either me or one of the people that I work with will answer you and let you know how you can do a program there. Or we do everything from workshops to individualized improvisational role playing that we discussed in the beginning. So there's a variety of different things. And each doctor, I'm told, will have about 200,000 patient interactions before they retire. And we've trained on an individual basis over 4,000 doctors, all residents and senior physicians. And so I feel that we can really have a ripple effect here now, and that we keep pushing this and remind the human connection. We're at a point right now where we're really at an inflection point. If we're not careful about remembering our why, then we're going to continue to deteriorate into a robot medicine with no feelings or connections. And that would be the biggest tragedy. If you're interested, just go through the website or contact me at my email.
Thank you for all your work, and thank you for your time today. So many gifts you've given our community. Thank you so much.
Thank you, sir.
Thank you, Herb. It was a pleasure.
When you start with PCC, you get more than an EHR. As an active participant in the pediatric community, we're proud to offer a lively peer community of PCC EHR users, a free annual users conference, and new resources that empower you to prioritize your patients. Learn more at pcc.com. Again, pcc.com.